My name is Jim Pellicane. I'm a breast surgeon and the director of breast oncology at Secours Cancer Institute in Richmond, Virginia. I've been asked to give just a very brief overview of how we are managing some of our breast cancer patients in the COVID-19 era, utilizing genomic profiling with MammaPrint and BluePrint. I think it's important to get accurate risk assessments, and I think that genomic profiling has to be a part of that when you're making decisions about who you can delay surgery on and who you cannot. So with that, I'm just going to break into just a very brief overview of how we consider doing things in Richmond. And again, in all this is the disclaimer here is that all these examples are really dependent upon resources and institutional guidelines. They really are guidelines and does not remove clinical judgment for our patients, as long as we all realize, as we always do, to not put their patients at any undue risk. So with that, I'm just going to go through 4 quick studies just to really show how we utilize MammaPrint and BluePrint as opposed to other genomic assays. So the first patient is a 71-year-old female. She has a 2.8 centimeter infiltrating ductal cancer, which is 100% ER and PR positive, HER2 negative, low to intermediate grade, and clinically node negative. Her MammaPrint and BluePrint were sent on a core biopsy, which is what we generally do with all our patients, pre or post-COVID. And it revealed a luminal A subtype with a very low MammaPrint index, consistent with what would be considered an ultra-low tumor, anything over positive 0.355. And these patients have been shown in some studies to do quite well with limited endocrine therapy, although the recommendation still for her would be at least 5 years of adjuvant endocrine therapy. For a pre-COVID patient, we would take this patient to surgery, generally speaking, do breast-conserving surgery plus minus radiation, where she would be evaluated for that postoperatively, and then offered adjuvant endocrine therapy. In the COVID-19 area, this is a great patient to postpone till after this crisis is over with neoadjuvant endocrine therapy for up to 6 to 9 months, if not longer, provided she doesn't show any signs of progression, then followed by surgery, an evaluation for radiotherapy, and endocrine therapy. The second patient is a 62-year-old African-American female with a 2.8 centimeter tumor, 100% ER positive, 90% PR positive, and HER2 negative. She has an intermediate grade tumor, but is clinically node negative. However, she is obese with a past medical history of diabetes and hypertension, consistent with what would be considered metabolic syndrome. She had a recurrence score run, which was 16, but her BluePrint and MammaPrint revealed a high-risk luminal patient, or luminal tumor, a luminal B subtype, with a MammaPrint index of negative 0.445, which is a particularly high-risk tumor. And this is important in that one of the benefits of MammaPrint and BluePrint is it's not impacted by other comorbidities. Given the fact that the estrogen receptor is not weighted in MammaPrint, anything that makes the estrogen receptor overexpress won't affect your risk score. So pre-COVID-19, this patient would be taken to surgery, generally for breast-conserving surgery. She would have a portacath placed in anticipation of adjuvant chemotherapy after being evaluated by a medical oncologist, followed by radiation therapy and then endocrine therapy. In the COVID-19 area, we would consider this patient for neoadjuvant chemotherapy, followed by surgery, radiation therapy, and then endocrine therapy. But of course, depending on resources and depending on your institution's guidelines, you could consider the pre-COVID pathway, or you could consider neoadjuvant endocrine therapy for a shorter course, maybe 1 to 3 months, followed by surgery and then adjuvant chemotherapy. Again, there's a lot of pathways with this patient. A lot of it is clinical judgment. It depends on what's going on in your institution. The third case is a 46-year-old premenopausal patient with a 2.2 centimeter tumor, 90% ER positive, 30% PR positive, HER2 negative, with a grade 2 tumor and clinically node negative. However, her BluePrint revealed a basal subtype with a MammaPrint index of negative 0.978. And this is a typical estrogen receptor positive basal subtype patients that we might see. These are particularly aggressive breast cancers, and really MammaPrint and BluePrint are the only assays that can pick up this subtype. We see this up to about 19% of patients in the NBreast trial, which looked at over 1,000 patients, up to 29% in iSpy, and about that same percentage in the Flex trial where these patients are being found. And these are real patients, again, with particularly aggressive breast cancers. We generally would treat this patient the same pre-COVID-19 or in the COVID-19 area with neoadjuvant chemotherapy, followed then by surgery and radiation therapy if she had breast conservation. And the last case study is a 56-year-old patient with a 2.1 centimeter tumor, Again, 90% ER and PR positive, HER2 negative with a grade 1 tumor who is clinically node positive with what appears to be a single lymph node on ultrasound, which was biopsied and revealed metastatic adenopathy. However, her MammaPrint and BluePrint came back low risk with a luminal A subtype and a MammaPrint index of positive 0.125. And again, we're looking at data from MINDAC. This patient would not benefit from adjuvant chemotherapy, and therefore, again, would be a decent patient in the pre-COVID-19 era to take for surgery, for radiation therapy, followed by adjuvant endocrine therapy. However, in the COVID-19 area, this is a patient we would consider for neoadjuvant chemotherapy, despite the neoadjuvant endocrine therapy, despite her positive lymph node. We'd follow that with surgery, radiation therapy, and then endocrine therapy for 5 to 10 years. So that's really it. I hope that this was somewhat helpful. Again, just a guideline depending on institutional guidelines and personal preferences and clinical judgment. A note to all of you to stay safe out there. And again, I appreciate the opportunity to just share with you how we tend to manage our early stage breast cancer patients in the COVID-19 era in Richmond. Any questions, feel free to email me at that email address shown. Thank you.